Good. So moving on to our next session is Patience as a Virtue. I'd like to introduce you to Dr. Stuart Nichols. Stuart will lead a panel discussing the importance of patient engagement and some of the patient experiences with it. This session will conclude with two short sessions or presentations outlining common challenges faced in patient-oriented research and ways to address them. A bit about Stuart. Stuart is at the Ottawa Hospital Research Institute, is a strategy for patient-oriented research program facilitator there, as well as he heads up the Office for Patient Engagement and Research Activities, what we call OPRA, at the Ottawa Methods Centre. And so, without further ado, take it away there, Stuart.
All right, thank you very much. So I'm very looking forward to hearing our speakers today, but before we get going, I just want to acknowledge that the Ottawa Hospital sits upon traditional and unceded Algonquin territory, and we have the privilege and responsibility to serve First Nations, Métis, and Inuit, and to demonstrate respect for the contributions, culture, and traditional knowledge of all Indigenous peoples. So why is this session called Patience as a Virtue? I wanted to sort of highlight two aspects. The first is, both of these link to some of the drivers behind patient-oriented research and patient engagement. The first is to illustrate the importance of engaging patients because of the sort of moral or intrinsic properties that engaging people who are impacted by the work that we do or the care that's delivered on the basis of the research we do is the right thing. They are the end users, the recipients of that. But we also have sort of instrumental or more practical reasons, and we've heard a little bit about that today, about patient engagement can improve the quality of the research on a very practical level. So I think this idea of patience as a virtue taps into both of those drivers that often push forward our patient-oriented research. It's also a little bit of a play on words, and we just heard from Christian, and we heard a little bit from Childbright about the time that working with patients takes, time to develop relationships, that we have to invest to ensure we get the research right. So it sort of touches on all those different aspects. And I hope, I think thinking back to Walter's comments this morning about how do we know we're doing good engagement, I think thinking about those two drivers, the moral reasons, thinking about why we're doing it, and then the sort of impact from a very practical level can really sort of help us when we think about evaluation. In terms of what we've seen since sort of the last 10 years with SPORE and the Ontario SPORE support units, I think one of the things we've really seen is a change in the landscape of research. Personally, I think I'm seeing in my role a change from people saying, why should we do patient-oriented research and patient engagement, to how should we do it? How do we do this well? And I think that's a lot of what we'll hear about today from the panel. But I think we also have to be mindful that just like the landscape in the picture, we have to ensure that we continue the work and that we have the resources and the right conditions for growth and success. So never want to miss an opportunity to plug some work. This was a little example of some of those things I was just talking about, and some of the impact awardees that were funded through OSU, and we asked them about the impact that patient engagement had on their work. And whilst the specifics were quite different across the projects, one of the things, and again, we've heard this morning, was it made the research more relevant to the people in the study, but also relevant to the patients who are going to be the end users and impacted by the results of that research. But we also saw impact on the researchers, and again, we've heard that through some of the presentations today, that researchers learned about the patient perspective. They got a greater understanding of the impact of their work. And again, this is what really sort of, I think, has contributed to a lot of that change in the landscape that I mentioned, is that the research then changed their next study project. They changed the way they did research. And again, it's sort of building this sort of snowball effect that we've seen, I think, over the last, say, 10 years or so. So I'm delighted to have this amazing panel up here and online. Terry Horish will begin our presentations with a virtual talk, and then we'll have a presentation from Lisa Duffett and Carol West about CAMVector. And last but not least, Samira Chandani, Annette McKinnon, who will be talking about a very specific project, which again leverages these great links between different SPORE-funded entities. So I'm going to hand over to Terry now and take it away. I don't know if you need me to forward your slides, but if you do, just tell me when to go.
Oh, hi. Can you hear me, Stuart?
Yep.
Yeah, I'll ask you, I'll prompt you for the slides if you don't mind.
Sure.
All righty. Okay. Next slide. Well, good afternoon. My name is Terry Harish. I'm a semi-retired professional engineer and survivor of a rare form of cancer. Very pleased to be here to share some key experiences and insights from my participation in patient engagement, more specifically on the cancer clinical research side, as both a patient partner and what I call a patient advisor. So my interest in patient engagement evolved from really a desire to understand my disease and its therapeutic approaches, which really gave me a sense of greater control over my journey with the disease. And this led to an interest in clinical cancer research and feeling of wanting to contribute my lived experience to try to better the lives of others through improved patient-oriented outcomes and experiences. And I've been at this since 2015 and had the wonderful fortune of having the opportunity to collaborate on a wide variety of roles and activities. And on an optimistic note, since my first patient engagement role, and thanks to organizations like SPORE and OSU, really witnessed an increased awareness of the importance of patient engagement in clinical research and its increased impactful adaptation into all stages of clinical research. So very grateful to be here today to share you with, I guess, a retrospective view of my involvement in patient engagement and a few things that I've learned on the way. Next. Okay, so what is patient engagement? Patient engagement is about meaningful collaboration. Patients become partners and advisors in the research project and are actively engaged in priority setting, developing the research question, and even performing certain parts of the research itself. And this type of participation really helps to ensure that the research being conducted is relevant and valuable to the patients that it impacts. So the terms patient partner and patient advisor, these are overarching and really inclusive of individuals with personal experience of a health issue. Such individuals include, of course, patients and informal caregivers like family and friends. Both groups are a truly patient community group that really makes significant contributions to the betterment of how we do clinical research by really offering up our lived experience. So patient engagement is really important, as I'm sure you have heard today, and really improves the relevance of the research, its accessibility, and its uptake into the clinical use. And regarding the last bullet, I really like this quote, is that really tells us why we're here in a very simple and effective way. And let's see, next slide. So I thought we just briefly talk about how patient partners are involved in clinical research based on my experience. Next. Okay, so the following slide shows typical ways in how a patient partner can be involved across the multiple stages of clinical research. And in this slide, what I do show is I show the, four buckets of particular stages associated with clinical research, starting at the beginning during the trial design piece, and then prepping for the clinical research or clinical trial, the conduct and at the end, the analysis of the results and its dissemination. And under each one of these buckets, in these columns, I've included specific activities that patient partners do get involved in clinical research. And I'd like to go through each one of these and could probably talk about 10 minutes on each one of them. But anyways, as you can see, the activities, there's really a wide variety of different activities. And, there's each clinical trial program or research program is a little bit different, and activities do vary from program to program, and is hopefully spelled out in a very, very good patient partnership plan that is developed, during the trial design stage. Next. Okay, so listed here are examples of typical patient advisory activities and roles that also support and enable effective and meaningful patient engagement in clinical research. The patient advisory type of engagement, and I've made a little bit of a slight distinction here from patient partners. It does not involve patients being directly involved in the stages of clinical research like a patient partner, but they make important contributions towards making things like patient engagement, governance, better methods, good training and advocacy that make it more impactful and effective. So here's the list here: participation in patient family advisory committees, governance opportunities through committees and boards, advisory councils, being involved in quality review teams, getting involved in the mentorship and training of others through toolkits and webinars and documents. And that is training other patients that are interested in patient engagement as well as researchers as well. Getting involved in the research application funding reviews and progress reviews, and being involved in the advocacy and promotion, of course, which increases awareness and adaptation of impactful research. Next. So I thought it might be interesting just to show some of the organizations and institutions where I've contributed along the way and learned as a patient partner and patient advisor, and been involved in many of the activities that I described in the previous slides. Shout out to these places where I feel I've had very impactful and positive experience. I won't mention the negative ones that I've regretted. But common to all these organizations are supportive, institutional patient engagement policy and awareness, effective and useful methods that support our contribution. Our input is highly valued, and they operate within really a very, very constructive team environment that recognizes, patient and partners and patient advisors as part of a team. And so I started over here in the upper right-hand corner with the Leukemia and Lymphoma Society, and the clockwise is a chronology of my participation. I won't get into the acronyms. I think you probably know most of them anyway. But my advice to patient partners and patient advisors is to match your participation with your research interests, your lived experience, your availability. Be careful not to get too saturated. And for me, my personal interest in this field is high, and I want to take on as much as possible. But if you're not careful, it could lead to oversaturation and burnout. So seek the good balance between health, family, personal time, and work commitments. Yeah, not easy, right? Next. Okay, so here's some enablers, benefits, and challenges associated with patient engagement. Next. So what are some of the key actions and approaches that researchers, patients can utilize that contribute to successful patient engagement in research? Well, patient partners should be engaged early and provide input into things like the research question, design of the clinical research studies, so patient outcomes and patient experiences are considered. The adaptation of EDI principles is so important to ensure the demographic relevancy of the research. And, getting the geographical and cultural mix just right is a difficult and time-consuming task, but very, very important. Good early onboarding of patient partners to better understand the research basics, research process, timing, roles, which really enables orientation for the patient partner, builds their awareness and appreciation of the study. And that patient partners being treated as part of the team is absolutely critical. Mutual respect and professionalism is important in the team dynamics. Clear, regular communication, collaboration, and support all lead to a positive team dynamic, and that enables good PE. So supportive institutional policy methods and framework, and connection with patients and patient groups, and which really helps good two-way knowledge dissemination, and also a source of recruitment for patient partners. And last but not least, supports compensation and recognition, I think is really important for the valuable input and time spent and sacrifice of those involved in patient engagement. Okay, so next. So what benefits do clinical research stakeholders receive from good patient engagement? And leads to stronger funding applications. Research has greater relevance to the patient community with its input, patient partner input across all phases of research. The research teams also benefit from new perspectives. We can bring other skills to the research team, but lived experience is really what trumps everything. We help develop plain language and lay materials to help enable knowledge translation to those non-technical. Help supports improved trial participant accrual and retention. And effective and meaningful clinical translation of research is enabled, and everybody learns and grows together. Next. So what are some of the key challenges and tasks associated with patient engagement in clinical research? Here's a list of some chronic issues that continue to plague patient engagement, but are slowly being eradicated with improved formal training and awareness. Pretty much the antithesis of what I listed in the preceding enablers of patient engagement slide, but not reflecting the demographic study of the study focus. Inadequate numbers of patient partners involved, the whole issue of tokenism and improper power dynamics, inadequate policy training tools and changes. This is one really gets me, is the changes, sudden changes in the research program priorities during the conduct of the research. As patient partner, it's frustrating. Sometimes you're left in no man's land because of changes in protocols and back to square one. So patients also feeling unprepared or a poor fit for the research activities due to poor onboarding, budget and resources not adequately identified for patient partners. And, these research cycles can be a very, very long time, and you may have difficulty in sustaining participation. Next. So in summary, leave you with some key thoughts regarding patient engagement in clinical research. Has become an accepted practice and definitely come a long way. Improves the relevance of the research, its accessibility and uptake into clinical use. Patient engagement early and in the research cycle is very, very important. Research programs are all different. Patient engagement plans should be jointly developed with patient partners and customized. Effective patient engagement is really about people working together in a respectful, supportive, collaborative manner. Still some work to do, but policy, awareness, training, support, it just continues to improve every day, which is very, very encouraging. Next. So yeah, so thanks for listening. Thanks again to OSIP for organizing this wonderful event and for the opportunity to share our knowledge and experiences with you today. So that's it. Back to you, Stuart.
Great. Thank you very much, Terry. I'll now hand it over to Lisa and Carol.
Good afternoon, everyone. And the problem with this time slot in the afternoon is that many of the words that you've heard today, you're going to hear again. And I think that's probably a good thing. My name is Carol West, and I'm a patient partner with the CanVector Network, and I'm co-lead of the Patient Partner Council. And with me is...
Hi, I'm Lisa Duffett. I'm a clinician and a research with the Ottawa Hospital.
And I will say Lisa is the co-lead of the Patient Partner platform and is our constant inspiration and light that brings our group together. You know, I was thinking on my name tag I should have something that said, nobody wants to be a patient partner. Because a patient partner means you've been a patient, and it means that something has gone wrong or something unexpected has happened. So it's not as though, you know, we're all clamoring to become patients and to have various ailments and challenges in our lives from a health perspective. But it is the opportunity to be a patient partner once something has gone wrong and you've in the medical system and perhaps have participated in a clinical trial and had a good or bad experience as a result of that, that we appreciate the opportunity to be here. And I do have one question. This is the first time I've participated in something like this, and I do have one question. I mean, does everyone do James Lind Alliance PSPs? You know, we thought we were coming here, and we were so excited about this piece of work we've done, and it was so motivating for our patient partner group, and then I hear about it a couple of times already today. So that's where we are. So our objectives today are really threefold. First of all, to describe the elements of our patient partner platform. So again, from CanVector's point of view, who are we? And I think relatively speaking, because you know we're surrounded by a lot of very mature and effective patient partner organizations, Lisa will talk about our history. We're young, and we'd like to tell you a little bit about ourselves and how we got to where we are today. The fact that Lisa and I are doing this jointly, and I will let her get a word in edgewise, I promise, is part of our integration and part of how we work together as clinician, physician, researcher, and patient. Secondly, we want to highlight the value of patient partners in research through some examples. You've heard so much about this today, and there's been so many inspirational things. Again, I mentioned Lisa as our leadership and support within our council, and that support has been throughout CanVector, and I try not to miss an opportunity to thank everyone who has been so supportive of our small group. Our theme today is about strengthening. We're not brand new. We want to give you some examples of how we believe we've demonstrated value, and we've done that in a variety of ways. And thirdly, we want to describe what we think are some strategies for success, for conditions for success. What we think has been important to what we think is our success and what we need to do in the future. So with that brief introduction, over to Lisa.
Thank you, Carol. So just a brief word on our history. So CanVector was launched as a national network for venous thromboembolic research in Canada in 2015. And it was initially funded by ICIH, our Community and Development Program grant, and now extends into phase 2 of the network through self-sustaining means. What I'm really proud to share and think really unique to our network is that it was co-built with our patient partners right from inception. I had the lovely pleasure of meeting and becoming a partner with people like Carol right from the beginning. And integrated into our network is not patient partners as a side council or an advisory group, but part of it, all of the mandates and all of the meetings and the decisions and the what it is that our network does. And so I think that's something that I'm quite proud to describe and share. I thought we'd touch a little bit about who our patients are, our patient partners, and what they represent, and maybe a little bit about what they don't represent. And I think this is a topic that came up earlier. So in general, our patient partners, and I say patient partners, but they're really persons with lived experience, and they would include caregivers, family members, or people who have lived experience and had a journey to share through an encounter with venous thromboembolic diseases. They're often referred by clinicians, sometimes referred by research staff when they've been a participant of a research trial and sort of demonstrated a desire and a want to sort of give back to the research community in a different way. And sometimes a patient partner will refer another patient partner, and so from their own patient networks and communities that they've joined. We meet with our patient partners and we discuss their expectations and describe our program and make sure that we have a good fit. We look for the people that are inquisitive. They're often the people that ask those difficult questions to their clinicians who maybe as a participant of the clinical trial wanted to know a bit more about the research process itself and how things come to be. We want opinionated people. We want people who challenge the dogmas and the thoughts of the clinician researchers, but also that value of a two-way communication and being careful that it's not coming in with just a one-tracked agenda, that we're willing to share in that two-way communication, which we openly discuss at our first meetings with potential people who are joining our group. And finally, we look for people who are ready to see beyond their selves and generalize to the many, because we are a small group of patient partners. Often our patient partners will have had some time to have with their lived experience and not necessarily fresh or in crisis with our own health. There's an acceptance and learning about yourself and then being in a position in your life where you can kind of give back and give to the community. And we talk about that with our patient partners. And we've met patients who come to us and they're clearly in a personal health crisis. And we talk about maybe that's not the right time to focus on others when maybe it's yourself to focus on. But we're not necessarily representing the opinion of every patient. The patient partners themselves are the first to state that. Two of the examples that Carol and I will share of actually funded Empower Awards, where our patient partners do go out and reach a broader community and do outreach to get a broader perspective. And it's important to understand when that is needed and when more of an in-depth collaboration on projects with one of our patient partners work. Carol?
Thanks. Now, this isn't the most exciting part of what patient partners do, but we do have a focus on structure and governance in the Patient Partner Council, and I'd just like to highlight some of the things that are of concern to establish a framework within which successful patient partner mechanisms can operate. So first of all, in our organization, we only have 8 to 10 patient partners, and in fact, we're recruiting. So anyone who has had, experience with our condition, please talk to us later. Again, the reason it's maybe not sufficient is we try and have 2 patient partners allocated to every project that we undertake. For a number of reasons. We try to do mentorship of new patient partners, and again, it can be a heavy load if there's 3 or 4 out of those 8 to 10 always doing the heavy lifting. So again, we're looking at expanding that slightly. We don't want a huge group of patient partners because we realize not only do we need to keep our researchers happy in terms of the contribution patient partners make, but we need to keep our patient partners happy as well to feel that they're making a meaningful contribution. We have co-leadership. If you've seen, Lisa and I are joined at the hip most of the time, and very happily so. So it's not just an idea, but it is a reality. We have an open onboarding process, and process is the key word there. It's transparent. There is a process. There's an interview piece. Lisa talked about the importance of the suitability of a patient partner for the work that we do. We do have monthly meetings, and we try and be as flexible as we can for people who are at different points in their life, with small children, with jobs that don't allow them to be available during the day, whatever, we try and accommodate as best we can. We have shared decision-making, and again, that's been mentioned more than once today. One of the examples is our compensation model, where we had, again, extensive discussion and collaboration in terms of shared decision-making with respect to compensation. And finally, training and mentoring, putting some processes in place to ensure that once someone joins us, that they have the right tools and that they have the resources of other patient partners and Lisa to support them. Just some highlights of patient contributions. And we have a couple of big projects that we're going to highlight for you in the next couple of slides. But, you know, with all of this, there is a balance between those of our patient partners who want to be private, and there are people like me who are old enough not to care. And I'm sorry, I mean that, you know, totally facetiously, but, you know, again, part of being a patient partner, as you've seen today, is the sort of evangelical spirit that some patient partners are able to bring to the conversation and to the reality of working as a patient partner. So again, a handful of our patient partners would never be comfortable doing that. They're not comfortable to be exposed. They're not comfortable even with their workplace knowing what they're doing. So again, that balance between privacy and exposure is a delicate one and has to be respected. And once again, it's been said before in this conversation, but you know, we like to make, and we do make contributions at every stage in the process, and we say the earlier we can be involved, the better. We've heard that from other presenters as well. And communication is the key, starting with even a letter of support and other things. One of my first assignments as a new patient partner, I can't remember whether it was, and I love knowledge translation. I love working with words, and I love trying to make them easily understood in simple language for people. But so one of the first jobs I had was, I can't remember whether it was a consent letter or a letter of support, agreement, or a letter of support for a researcher. And the quite formidable doctor who was heading up the KT little organization said to me after, he said, you know, you were really just too nice. I said, what do you mean I was too nice? And that speaks to another challenge. It's not all easy. You know, there's the intimidation factor of, you know, we're not medical professionals. I mean, we might have had some success in other careers. We do other things in our lives, but we're not medical professionals. And there's that intimidation possibility that you are not going to speak truth to power, so to speak, to take a political term. But again, I didn't forget that, and I'm much harder now than I was when he said, you know, you have to be nasty. I said, that's not my nature. And he said, well, you know, work on it. So I did. Just a couple of words again about stages in the research cycle. And again, others have pointed this out. And, you know, to be part of the whole project is really so gratifying to a patient partner. Because part of this, and I think someone else may have mentioned this today, part of this is there's delays. There's times when you're hanging around and not feeling very useful and you're not sure why. And it may be, you know, as we've learned, the ethics review process takes a really, really long time. And for those of us who are used to working in other milieus with other consent processes and whatever, it just seems to be a really long time. So from the time that, you know, we could be involved with the development of the research question right through to knowledge translation and quality assurance, we've been very fortunate to be involved pretty much in every step of the research process. And there's a lot that we've done, and Lisa's going to talk about that.
Yeah, so I'm not going to read through this slide, but I like it as an example of the amount of work that our patient partners have done and the impact that they had. And as I look through this, I realize that it needs to be updated after the last couple of grant cycles. So each of these are a research project that has patient engagement involved in it through the CanVector network. And behind each of these acronyms, which by the way, our patient partners love to make fun of how we come up with these acronyms, is one or two patient partners who are spending their evenings after their kids go to sleep or their lunch hour during their other job that they do, contributing to research, and it's been quite a journey since CanVector started, to be able to get to the point where I have a slide that has such small font you can't read it because we've been so busy, which is so great. So Carol and I are going to talk about, another James Lynn Alliance. But two projects that we highlighted and we chose because we're quite proud of, and also quite thankful for the support of the OSSU through the Empower Awards to promote the knowledge translation in both of these projects. So the first is CLOP Top 10 Priorities. So I think everyone in the room is likely familiar with the James Lynn Alliance and its methodology and its importance in really getting that, that joint consensus and that listening to both the clinician and other healthcare professionals and patients and persons with lived experience in terms of setting priorities. So rather than share with you our process and similarities, just briefly, the quotes that we heard in our feedback, I felt that it was very respectful of others' opinion, and as a healthcare professor, my opinions on the priorities were influenced by hearing the patient's point of view. And isn't that the whole point of all this, right? To listen and to have our minds changed or our ways forward changed. And likewise, from a person with lived experience, I appreciate the diverse background of the participants. I changed the order of my choices and gained a better understanding of the topics that I did not choose initially. So to me, that just said we were effective at having an open dialogue and a communication when we established what now will be the mandate and the mission of our research network, which is to address these priorities.
Just one word about the VTE CLOT Top 10. It's World Thrombosis Day coming up in October, and one of the things that some of us fought very hard to have on that list was psychological impacts or mental health. And again, we're doing a webinar, a global webinar on mental health. So we're very proud that this links to the CLOT Top 10. The other project that we love and we're very happy with and engaged with is establishing an international core outcome set for clinical trials of VTE in adults. So again, the elements, things like what to measure, how to describe, how to define, patient-reported outcomes were just lacking and in this area. And again, considerable work has gone into the project already, and it continues. And the other issue is having agreement on how to measure, so that when you're looking at outcomes across borders in particular, and it could be provincial borders, not even international borders, but international borders are what this study looks at, it's really important to look at potential for standardization and harmonization. So that's a study that, again, we're very pleased with. Here again is the idea that we will have a standard set of outcomes for all VTE treatment studies, and our stakeholders are varied. I mean, they're not just patients and caregivers. Researchers, clinicians, policymakers, and funders have a stake in this, again, in a number of countries, and the international collaboration through a group called Invent VTE, which I think, again, from that point of view of standardization, harmonization, common language across borders, not just clear language from a patient perspective, is incredibly important.
And so Carol and I wanted to end off our presentation with just some comments and insights from what we would say is some strategies for our successful patient engagement, and also maybe introduce some things, some hurdles that still exist, and things that the future of this field, will need to continue to improve on. So certainly, beginning a process of patient engagement and research, I think wasn't without challenges. And I felt particularly in the research environment, it seemed to, the acceptance in a clinical care environment or in a public health environment where it's a very more natural link. But then with research, it was a little bit more of a resistance initially. And I think the world has passed that, but if you rewind, 10 years ago, it certainly was. Just common challenges, clinical language and practice being unfamiliar. We really put a lot of work at the request of our patient partners and built with our patient partners to providing glossaries which define acronyms. There's so many acronyms, and a living document that the patients could contribute to, because you come across new terms and they could share with each other. Links to lay language resources. Our patient group has developed lay language resources and translation of research findings into lay language, which has been quite important. Just generally learning to allow more time, understanding that this is volunteer work. Response of an email by the end of the day is not acceptable. Asking to review a grant a week before it's due is not acceptable. So building in those timelines and expectations, explaining that it takes 3 months to hear back from the grant. And so if you haven't heard, it's not because we don't want to work with you anymore. And so just laying down that sort of thing was quite important. And not always things that we think about. It makes sense to me that it takes a while to negotiate institutional contracts in people with busy careers, like Carol, for example. Things actually move at a different pace. And so actually having to talk about that up front and outline a timeline was quite important. Patients feeling left out and uncertain in how to contribute. One of our patients said at one point, just explain to me exactly what you want me to do. And that makes sense. If you're coming into a project that's already a clinical trial recruiting patients, clearly your opportunities for input and engagement, while still there, are different than if you're defining the research question and outcomes from the get-go. So just being very transparent, and this is exactly what's going to happen in this project. We developed a terms of reference document that is made with both the researcher side and the patient side, where we kind of outlined these sort of timelines, time commitments, expectations and processes, just as a way of formalizing and making sure that that discussion happens and not is implied. Carol has given an example that I always like, is being included and being called out. So a meeting where, on the agenda is patient partner input, so that if that patient partner at the meeting is not feeling to unmute and raise their hand, that there's an opportunity and a pause to say, okay, after hearing that, is there anything else that the patient partners would have to contribute? Patient partners are telling us that's quite respectful and they like that. Differences of opinion about the research. I mean, the point of engaging with diverse groups is about having differences of opinion, and that's fine. But being respectful, understanding that's consensus, which is important. Concerns about confidentiality and liability, and then just being transformant and informative to our patients. This one's mine. I think we may be over time, so I'll just, again, this next slide I think is just the same messages, just defining roles and expectations, and being transparent and open communication so that the expectations aren't implied, but they're explicit. And I'll leave it to Carol.
Showing that we follow directions as patient partners, we'll wrap up. The world is about relationships, and again, all of the things on this slide about the future are about relationships and relationship building. So I'll leave those thoughts with you. And far be it for me to quote Mother Teresa, but there is a quote that reminded me of patient partnership and how we work with all of you in the room. I can do things you cannot, you can do things I cannot, and together we can do great things. So from my point of view today, again, a first-timer here, there have been some recurring messages, and it's shown that we can do and have done and will continue to do great things. So thanks a lot.
Happy to be here today. Oh, excuse me. It was so easy for Carol and Lisa. Can you hear me now? Samira and I are happy to be here today and share our experiences as patient partner co-leads on a scoping review We're going to talk about how the experience of being co-leaders worked for us. And we'd like to start by changing our slide. I can't change this slide. Yeah, Stuart can change. Hopefully this will work. So we'd like to start by thanking our partners at Ontario Spore Support Unit, Vasanthi, Hillary, and John, and the Patient Partner Working Group, who we're part of. And at the Evidence Alliance, we'd like to thank them for accepting our query and for their work in starting to change the landscape. And thanks to Linda Lee for her Dr. Linda Lee for her amazing support, and Ellen Wang for her support, and the team for their inclusive partnership. And next slide, we're at slide 3. And Samira is taking over from here. Okay. You can only see one slide? Okay. Our slides don't seem to be here. But the slide that you would be looking at has to do, and luckily we have no charts, we have no heavy print, nothing much for you to read. It's mostly pictures, so we'll have to paint the pictures.
So if we email them right now,
No,
it's too late.
it's, yeah,
You already sent them.
yeah, so Samira is talking,
Okay, that's
yeah,
fine. Okay.
people.
So the slide that we were going to have was basically depicting a patient sitting on a wheelchair. And I'm going to be talking about Chimamanda Adichie. In her TEDx talk, she discusses the danger of a single story. And what she says that the only story that people around her that they knew was that of poverty. They didn't know any other stories about her. And, you know, a single story can create a lot of critical misunderstandings. Similar to Chimamanda's story, patients and caregivers are often just seen in relationship to their illness. They're not seen as people having other stories. And getting to know patient partners can help researchers and team members to build relationships and can make the partnerships mutually beneficial.
On this,
Yeah, go ahead.
on this slide,
This is a better way of doing it.
yeah, on this slide, we have a picture of a rubber tire swing, and right beside it, there's a picture of a person relaxing in a rope swing that's also hanging from one support.
So what we're really trying to depict in this picture is that when patients are engaged as partners, you have a swing where someone can sit. There is a nice bench. It's got nice two things on the side that you can hold on to, unlike the one that is the tire where no one can sit. So I guess what we're really saying is that when patients are engaged, you know, that there can be a better outcome. And so when patients are engaged as co-leads, they bring a patient lens and they can help redefine the project scope and perhaps make it more relevant to more people. And engaging patient partners right from the inception and including the patient lens can have a greater impact on the output and the usability of the research. And so I'd already talked about that. Okay.
Yeah. Now, this is about the context. You would see a slide that said context and has pictures. Our query was a scoping review to look at tools, strategies, and approaches to anti-racism in patient and public partnership in research. So we wanted to find out more about the patient and public partner experience on research teams, hoping that that would improve the equity, diversity, and inclusion among the patient partner authors and the team members. And the idea for our review began at a patient partner working group meeting as we discussed the lack of diversity among patient partners on research teams. And for racialized communities, as Samira is telling me, there are even fewer opportunities. Oh, there's our slide. Samira mentioned that despite her experience as a community-based researcher for over 15 years, she wasn't seeing much opportunity to participate on research teams. I suggested that we should submit a query to the Evidence Alliance to understand if there were any research papers related to our experience. So we're on slide 6 now, the process. Oh, back to the process. Slide 6. All right, good thing I started with the thank yous. So,
They want to see the swings.
oh,
Show them the swing. Show them the swing.
yeah, and I'll keep talking about process. Oh, okay. I hope this button works. Yes. So that was, we have to go backwards a little, I think. No, we don't. Maybe our slides are a little shuffled.
No, they're not. You can just keep going
I
back.
can find the swing.
We're
My
having fun
patient,
today.
our vision of the swing is just,
There
there
it
you
is.
go. The patient vision and the researcher vision. And the idea is that using these two lenses, we bring things into focus, almost like you have binoculars. You have to focus each eye to get the good picture. So process-wise, there's the danger of the single story. I'll tell you about the Evidence Alliance. They answer organizational and patient-initiated queries through scoping and systematic reviews. So the patient partner working group, with the help of Eddie Nason, worked together to make our query more research-friendly. As the query went from OSU to the Evidence Alliance to the research team, it was further refined at every step. And we learned through this that not every research question is perfect at the first appearance. As initiators of the query, we had the opportunity to select the researcher ourselves, who then gathered the rest of the team. We had 5 co-leads on the project, 2 of us, the patient partners, the primary investigator, our research assistant, and a content expert from OSU, that was Hillary. And we also had 6 trainees, a librarian, and a research admin support person. So it gives you a good picture of how large the team was, even for a scoping review. And when we negotiated the work plan, we saw our roles as co-leads involving us in all aspects of the research process, from the work plan to the keywords, the abstracts, the article reviews, and on to writing the report and the knowledge translation. Not every patient wants to have this level of involvement, but we really wanted to be thoroughly involved in the project. At our initial team meetings, we got to know one another, and we discussed the ways we would work together. At this planning stage, after the planning stage, we started the abstract screening, and one tool we really appreciated using was Covidence, which researchers all know very well, I'm sure, but for patients, it's a way to track the work that's being done. And so all of the data from all the 24,000 papers that were extracted was in Covidence. And so we all had access to the same data, patients and researchers. And it was very reassuring to watch the work happening. And now we're on to Samira and our experience. And
So throughout our work on this research project, there were 2 major themes. One was of the lens, which was like the patient lens and the researcher lens, and the negotiation. So there was always negotiation because there was the researcher lens coming through and there was the patient lens. So trying to negotiate and trying to find a balance. And, you know, we were a team of diverse team, and that meant a lot of diverse perspectives, and it was negotiation, 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 and trying to come to a consensus. And so, for example, we had to, like even when right in the beginning, we had to negotiate the number of hours. So it was assumed, for example, that 25 hours was enough. We were co-leads on the project, and 25 hours was not going to be enough. So we had to negotiate that, and we negotiated it up to 100 hours, which we still found was not enough. Or, for example, when we were doing the keyword search to look for papers when we were extracting, and even there we noticed when we were looking at the keywords that we needed to suggest additional keywords to make sure that the papers that we were extracting were going to be encompassing of all the racialized communities that we were looking for. So I think this is showing that, by adding the patient lens on top of the research lens, how it can make a difference. So as there was negotiations going on at the team level, Annette and myself were having our own discussions and negotiations too. We both came from diverse backgrounds, diverse experiences, and so we had various discussions and negotiations of our own, and making sure that we came with a unified lens to the table also. So it was really interesting, having those negotiations. And as we were going through the project, we found that the trainees had not worked with any patient partners before. And so for them, it was really interesting to learn and understand what is patient partnership. How is that different from just general patient engagement, looking at the patient, the letter of patient engagement, and understanding that, okay, we were co-leads, how is that going to be different from just advisory? So it was capacity building, and there was mutual capacity building, where we were teaching the team, about patient engagement, bringing our lens to the table, and there was the other side where we were learning how to use things like Covidence, how to do scoping reviews. So there was mutual learning at that point. And for example, when we went into the literature search, we just found one paper that had a patient lens or written by a patient. So it just highlighted the point that there was a lack of patient lens everywhere that we looked.
Experience.
So in terms of continuing with our experiences, we were really lucky because the environment was enabling, it was supportive, and everyone on the team, they made an effort to build capacity and support each other. And things like power sharing, balance, sharing the decision making, it requires an additional effort. And often teams are quite nervous about letting go of power, with their partners who are new to the process. But still, we were lucky that all the co-leads wanted the project to succeed, and hence they made an extra effort. What was really an advantage was having two of us as patient partners on the team, because it gave us peer support, and also it helped with the power balance on the team. And as a result of this, we built a really strong partnership. And we're looking forward to working with the team on future projects. And in terms of peer support, not only were we peer support to each other, we found through the process we were peer support to others around. There were lots of others who were coming to us and saying, how do we do this? You've done this, can you help us? So that was an advantage. And above all, we've proved that co-leadership is a possibility.
Yes. And as Samira just said, patience as co-leads on research teams is possible. And as Stuart said, it's a virtue too. It requires trailblazers like ASU and the Evidence Alliance, and support, transparency, and a commitment from all parties to work together toward the same vision. There's been a real sea change in opportunities for patients to be involved in research at expanded levels of engagement, but not so much for patients from diverse backgrounds. The overall increase, though, the mainstream part of it is becoming more visible, because in journals, patient authors and patient-authored publications have tripled in the last 3 years. That's from Professor Karen Woolley, who did a paper that's yet to be published. She says Maureen and Dave were the most common patient names. And in our own review, we saw an exponential increase in papers that refer to patients and caregivers as team members or partners. So we had a 20-year span for our papers. And in the first 15 years, there were maybe 12 at the most of the 66 papers we found. That means 80% of the papers that we found that fit were published in the 5 years at the end of our time cycle. And as another demonstration, the Evidence Alliance has accepted 20 more patient queries to put in the field in the next year, which is going to be huge because they've only done 3.5 so far as I know. And I'm not trying to say something against them because it's great to see patient-led projects, co-led projects. And so we've benefited from the changing culture that we're seeing in research, and we hope it will continue to grow. And thank you very much for your attention at the end of the day, especially. And there's our final thank you.
Thank you very much. I think in the interest of time, I will say that we are around to take questions, or you can submit questions online and we'll answer them after the fact. But I'll now pass over to Kerry Kaluski, who's going to moderate this final session about capacity development. I believe she's online.
Great. Thank you so much. And so lovely to be here again today and feel so inspired by the talks that I've been able to attend today, especially this last one with Sam and Annette. That was fantastic. And so I'm going to introduce an interesting sort of kind of KT event to close things off. And this is featuring really great presentations from a course that I lead and co-developed with many community members and ASU and faculty and students and other folks who are really have expertise in patient-oriented research. And it's part of a course that we developed 3 years ago. And as part of the course, students are asked as one of their assignments to pick one core challenge that they're learning about in their research related to patient-oriented research, or something that seems a bit understudied. And the whole idea is to creatively present just in 5 minutes with one or very few slides to really get at what is the core of the issue, what's the challenge they're digging into related to patient-oriented research, and what are some suggestions on how to address that challenge? And so when I approached John Riley and Vasanthi, I said, can we make space in our agenda to feature these really fantastic presentations from our up and coming patient-oriented research experts? And they said, absolutely. And I have to say, because of the support of OSSU, we've been able to involve patients and families and community members in the development of the course, in the delivery of the course, and they're also involved in some of the assignments in the course. And so when students deliver this 5-minute pitch, they're doing this to patient and community partners. And those patient and community partners then provide critiques and then facilitate questions to the students. And it becomes, amongst all of the students and their peers and patient partners, a really fantastic opportunity to think together, to learn together, and really grow together. And it really kind of shifts that power balance. So it's not about, researchers teaching researchers how to do patient-oriented research. We're learning with and from patients, communities, family members, and it's embedded in the curriculum. So today you'll get a feature of some of the work that we've dug into, 2 fantastic presentations. So we have Crystal Amog and we have Divya Mathura, and they're both U of T graduate students, up and coming, amazing experts in patient-oriented research, and you'll see their passion and the areas that they're really interested in as they go through their presentations today. So with that, I will kick it off over to Crystal, and after Crystal presents, she'll pass it on to Divya. So take it away, Crystal.
Hello, everyone. Thanks so much, Carrie, for the introduction. So today I'm going to begin by sharing a story. Earlier this year, I attended a conference, and there was a panel of researchers, policymakers, and patient partners who discussed challenges of integrated knowledge translation and patient engagement more broadly. What struck me was a problem that was identified by a patient partner, which was the idea of trauma and how we should strive for trauma-informed partnerships. After the conference, I reflected on this further. What exactly does trauma and trauma-informed partnerships mean in this context? How can we apply this lens in patient engagement work? And how else can we practically address this problem? Today, I will share with you some answers to these questions based on the literature and my own personal reflections. So how do we define trauma? There are varying definitions of trauma in the literature, but at the core, it is described as a lasting emotional response to one or more distressing events or circumstances. Trauma can stem from a range of experiences, such as abuse, grief, loss, violence, cultural and historical trauma, as well as the healthcare system and healthcare experiences. It is important to note that lived experience can be intertwined with experiences of trauma. In the context of engagement research, this means that certain discussions can trigger or cause patient and caregiver partners to re-experience difficult parts of their lives when sharing their stories for the sake of a project. By nature, traumatic events also create power differentials. Therefore, it is important that we don't reproduce these feelings throughout the engagement process. Knowing this, what can we do to mitigate or handle the situation? This is where trauma-informed engagement comes in. So I'm now going to quickly transition to some slides to share some strategies. Okay, hopefully everyone can now see my slides. So these are some strategies that can be applied at different stages of engagement, and I'm going to start with pre-engagement. So trauma-informed approaches should be applied at the beginning of a project. A framework such as Valuing All Voices, developed by Roche and colleagues, uses a trauma-informed, intersectional, and critical reflexive approach, which can be used to guide the engagement process. To complement this, research teams can utilize trauma-informed care, or TIC principles. The figure here showcases 6 principles that are suggested by Gum and colleagues. Some of these may look familiar to you, as the authors argue that these are consistent with patient and caregiver engagement research strategies. This means that many research partnerships may already be implementing strategies that foster TIC without even realizing it. Another key aspect is being transparent and reflexive from the outset. Patient and caregiver partners should be informed about the possibility of experiencing trauma or other emotions throughout the engagement process. This will give them the opportunity to decide if this is the right engagement opportunity for them at this time. If they agree to participate, there should be an open and honest discussion about what they would need in order to feel emotionally comfortable and safe. And it should be made very clear that they have agency over their stories and lived experience, so they can decide what to share or what not to share. Training is also another strategy that could be used, and this could involve a more structured module-based learning series like the one pictured here, created by Gum and colleagues, or simply taking the time to reflect individually and as a team on how trauma relates to the study and how trauma-informed principles can be applied to the work. Now, what do we do in the moment when someone is triggered? First, look for signs of distress. For example, panic, flushed face, shaking hands or voice, and help the person manage their feelings by using grounding techniques. This includes encouraging them to take deep breaths, sipping water slowly, or looking at an object in the room to bring them back into the present moment. You can also offer to pause, take a break, or move on to a different topic. And it's also recommended that if a person is triggered while sharing their story, we take the time to acknowledge the impact of what they shared and how it is influencing activities and priorities of the project. And finally, it is important to check in after the experience occurred. Take the time to ask the person how they are doing and what they may need. Also, offer a list of appropriate supports and resources within their community and give them the opportunity to debrief in a method of their choosing. For example, a one-on-one phone call or video call. Thanks so much for your attention. I'm going to now pass it over to Divya.
Great. Thank you so much, Crystal. I think that's going to be a great transition over to my presentation here. And let's just share my screen. Alrighty. So welcome everyone. My name is Divya and I'll be presenting for you today. So I'd like everyone to just picture this. Years ago, you're living a peaceful and plentiful life with your community and family. Then 60 years later, with the invasion and disruption of colonization, there's uprooted values of tradition, culture, and family. Assimilation, death, betrayal, uncertainty are just the few of the feelings you're experiencing. With the generational trauma of dealing with those in power who use and destroy your identity, how do you begin to trust again? Fast forward to the present day, and here we are working to build back the trust we lost. This is how many Indigenous people feel, live, and carry on throughout their life. How are Indigenous communities expected to participate full-heartedly with the same kinds of people like those in power who dismiss their culture, feelings, and way of life? This is what engaging with researchers can spark: a sense of being used, tokenistic, and dismissed. So my research interests are around making diabetes management more culturally appropriate. So engaging with First Nation patient partners will definitely inform how interventions will work. The challenges with engaging with Indigenous community and patient partners is rooted in their historical context, which hits on power dynamics, trust, communication, and team building. It'll be important to mitigate these challenges and deep-rooted trauma by building relationships with community and having educational background on their history, be open to learning about their culture. First and foremost, when engaging Indigenous communities in research, it's crucial to recognize their inherent rights, cultural diversity, and unique worldviews. We must acknowledge their rich history, traditions, and the wisdom that has been passed down through generations. By doing so, we demonstrate our respect and appreciation for their knowledge systems, and we set the foundation for building equitable partnerships. To develop strong relationships, we must prioritize active listening and open dialogue. Indigenous communities have invaluable insights and perspectives that can greatly enrich our research endeavors. By engaging in meaningful conversations, we can learn from their lived experiences, gain a deeper understanding of their needs and aspirations, and co-create research projects that are relevant and impactful. Mitigating challenges of trust and power is to build relationships, maintain consistent communication, and be open to new ways of learning. Indigenous communities approach research from a less formalized perspective, where presentations and Western ways of thinking and doing are not the traditional outlooks for learning. Adapting to Indigenous ways of doing and learning will be imperative to maintain trust and honesty. As this can be a new way of learning for me, it's important I maintain an open mindset to learn new ways of doing research. It's also important to maintain a vision of sharing knowledge rather than telling Indigenous communities how to do research. It's essential that I approach this task with utmost respect, cultural sensitivity, and a genuine desire for collaboration. By forging authentic connections, we can foster trust, understanding, and mutual benefits. Together, we can bridge the gap between academia and Indigenous knowledge systems, leading to transformative research outcomes. Research should not be seen as a one-time transaction, but rather as an ongoing collaboration. We should invest in building capacity with Indigenous communities, supporting their participation in all stages of the research process. As indicated by Sean Wilson, Indigenous peoples view research as a ceremony where everyone participating should be ready to be involved in a raised state of consciousness. The Indigenous views on research will be learned and adapted by myself to build a relationship on mutual understanding and trust. Speaking to patient partners before the research commences to understand their beliefs and culture on research will inform how I conduct and view research. Together, we can embark on a journey of collaboration, understanding, and positive change. Thank you.
I just wanted to say, Crystal and Divya, thank you so much for sharing and being open, and beautiful presentation. And I've learned, and we've all learned so much from you, and you've really demonstrated the powerful way to share your research and to think about relationships, to think about trauma-informed practices, to think about history and culture as we go about our work. So I'll leave it at that. And I thank you both so much for contributing this today. And with that, I'll hand it back over to Dean.
Great. Thank you so much, Carrie, Divya, and Crystal, for two fantastic, powerful, and helpful presentations. And that a fitting close to today's OSSU Research Day for 2023. We hope that you can join us for a reception to follow just outside those doors. And just a reminder that that survey via the QR code, very, very important to fill in. So if you can take just a couple minutes to do that. And I'll welcome Vasante to just give a few final words on the day.
Thank you, everyone, for attending, and those of our colleagues virtually. I really appreciate all the participants, the researchers, the patient partners, because it's their work that makes OSU what it is. Thank you so much for coming, Amy, to appreciate what your funding opportunities actually mean to the research community. I'd like to thank the face-to-face management crew. I wish Sally were here in person, but I know she's upstairs. Quick recovery, Sally, and thank you all, one and all, for doing everything that you needed to do and we expected you to do, and it's all wonderful. Thank you. And I would be amiss if I didn't thank my team, small and mighty. It's always the four of us. Hillary, John, thank you so much, Hillary, for doing all the tweeting today. I'm going to go home and appreciate what you've tweeted. Okay, John, thank you so much for putting everything together for us and publicizing this event. Thank you so much. Carolyn, what can I say? Without you, there's no movement here. So thank you. Thank you so much. Please join us for a reception outside, and thank you so much, Alia. You've done a great job. Thank you for taking over. Bye.